So my name is Elizabeth. I am a patient support specialist team lead for My Health Africa. So for My Health Africa, we are an online doctors booking platform. We assist patients to seek treatment regionally and locally and regionally, that is within Africa. So My Health is also incorporated with international medical treatment, whereby we assist patients to seek treatment overseas. So for overseas, we work with Bamrugard Hospital in Thailand, Apollo Hospital in India, and American Hospital in Dubai. So that's for My Health Africa. So this webinar, as said before, is we're going to be discussing all matters in regards to infertility. A recorded version of this session will be available in our social media platform. Please feel free to engage us, maybe ask your questions. Dr. Sarita will answer them at the end of the session. For Dr. Sarita, our guest speaker today, she is a gynecologist and a renowned fertility specialist. She has over 24 years of experience in fertility treatment. So she can just maybe explain herself. Sorry, maybe tell us more about yourself, Dr. Sarita, maybe your professional experience and all that, just for the audience to know more about you, Dr. Sarita. Dr. Sarita. We can't hear you, Doc. Okay.
Yeah, so can you hear me now? Okay, I think I'll have to log out from the other one.
Okay. Great.
All right. So, yeah. Yeah, you can hear me now? Is it clear?
I hear you clearly now. It's good.
So, I'm Dr. Sarita Sukhija. I am practicing in Nairobi now for almost 4 years. And before that, I was in India. I did my graduation and post-graduation from BJ Medical College, Ahmedabad, which is one of the second largest hospital in Asia. And after finishing my post-graduation, I did my senior registrarship from another busy medical college in Delhi, that is UCMS and GTB Hospital. And then I was into practice as an OB-GYN. for a few years, but because I had a lot of interest, my special area of interest was infertility and IVF. So I did fellowships from Cleveland, Germany, and then I did my master's in reproductive medicine and embryology from EV, Spain. And I've been practicing now IVF for almost 20 years now. And in Kenya, I'm here for last 4 years. And at present, I'm practicing at Myra IVF and Medical Center, which is located in Westlands near Sarita Center, Westwood Building. So I'm there right now. We have our state-of-the-art IVF setup with the modular lab and all the facilities available.
Okay, thank you so much, Dr. Sarita, for the great information in regards to your experience, your professional experience in matters of IVF treatment. We appreciate that. So maybe we could just dive into maybe causes of infertility, maybe give us more information, what is infertility and what causes infertility.
Yeah, so would you like me to do the screen sharing, or we can just...
Not a problem, that's okay.
Okay, so let me share the screen, and you can can you see the slides?
It has, yes, we
can.
can.
My slides?
Yes, we can.
Yeah, so that's a brief introduction about
Okay.
which I've already given you. And so basically, every girl is born with a certain set of eggs. At birth, it's about 1 million, and at puberty, and when a woman starts menstruating, it's about 30 to 40,000 oocytes. And in the whole reproductive life, a woman will ovulate approximately 400 times. And if there are any problems with the ovulation, the tubes, or the uterus, then a person can have difficulty in conceiving. So basically, we say that the person is having infertility when when a couple is staying together and they've been trying for pregnancy for a year, and still they are not able to conceive, then we say that they fall in the group of infertility. And that is when we should start looking at the factors, like what is the reason, whether it's a female factor or it's a male factor, and what's the age of the woman, what is the duration of the infertility. So there are a lot of things which we look into to find out the reasons of the infertility. So
Okay.
if we look at the female factors, age is the most important factor of both the partners, because the fertility levels decrease as the woman ages, and it's true for the male also. But in men, you can still find some sperms even if they are in the age of 55, 60 also. Then comes the duration of infertility. If the duration of infertility is longer and the woman's age is more, then we need to hurry up. And in case if a couple is young, say they are in the age group of 25 to 30 years, then we can still give them some time to try naturally. But if somebody if the woman's age is more than 35, 40, and they have been together and trying for even 6 months and she has not been able to conceive, then we should start looking at the causes of infertility, and look into the lifestyle, like alcohol, smoking. Nowadays people have a lot of stress and they are into junk food, and there are so many other factors. We need to look into that, and the menstrual, surgical, and the medical history, the physical examination, obesity, etc. These are some of the factors which we need to look into when a person is trying for a baby. For women, preliminary health is very important. Any woman trying to conceive should be on folic acid, which is supposed to give her protection from the congenital anomalies. And another important thing is the rubella vaccine, which is now available, and every woman should have this vaccine. And once the vaccine is given, they have to wait for 1 month as per the RCOG guidelines. Because rubella virus is something which can lead to a lot of malformations in the baby, and it can be prevented if a woman has been vaccinated. Then the thyroid and the prolactin hormones are other things which we need to look into, and thalassemia in both the partners if there is a strong genetic history of the thalassemia. Now, if you look at this picture, it shows the female reproductive system. So a woman has a uterus, the tubes, and 2 ovaries on both the sides. And usually the egg formation happens in one of the ovaries every month. And once the egg is ready, it goes inside the tube. We can see the next picture. You can see once the egg is released from the ovary, the tube will pick up the egg. And once the egg is in the tube, if a couple has intercourse, then the sperms will move up and fertilize the egg. So the fertilization happens in the tube. So from here, the fertilized zygote will start moving into the uterus, and ultimately it will settle here. But by any chance, if there is any obstruction here, if there is any infection or there are some adhesions, the pregnancy can get stuck in the tube. So it's very important to rule out the sac in the uterus early to rule out any ectopic pregnancy. So this is how the normal pregnancy happens. So again, coming back here, so there can be, in a woman, there can be problems in the uterus. In uterus, we can have fibroids, there can be some congenital anomalies, like there could be a septum, there could be some bands or adhesions, there could be adenomyosis. So there are a lot of diseases which can affect the uterus. Then coming to the ovaries, there could be problems of ovulation in a condition like nowadays we are seeing. A lot of young girls are having polycystic ovaries. There could be endometriosis, or there could be some hormonal issues like the pituitary is not producing enough hormones. So if a woman is not ovulating, then obviously she has difficulty in getting pregnant. Then there can be some tubal factors. So the tubes have to be open, otherwise the pregnancy will not happen, because the fertilization, as we saw, will always happen in the tube. So if by any chance the tubes are blocked, which can be because of some pelvic infections, or there could be some fimbrial adhesions, there could be tuberculosis which can damage the tube. So all these factors need to be ruled out before we start a specific treatment. So these are the female factors, and this is how the fertilization happens. So usually we first rule out the whether a woman is ovulating or not. And if you look at the history, if a woman is having regular cycles, and we can also measure progesterone levels. Anything progesterone which is more than 3 or 4 means she is ovulating. And then we can do the normal hormonal profile like FSH, LH, estradiol in the beginning of the cycle. And on ultrasound, we can have a look at the uterus and the ovaries. If it is normal, then we look at her ovarian reserve, and we can do the AMH, which all the young girls in their 30s must do. There's a fertility check which can be done by anti-Mullerian hormone, AMH, the normal levels of which are between 1 to 4 nanograms per ml. So every woman must check her fertility levels, and usually the AMH levels progressively start falling as a woman ages. So these are the things which we need to look into. And now the common problems which can cause infertility in a female As we discussed, there could be pathology of the uterus, there could be pathology of the tubes, or there could be pathology of the ovaries. There could be various reasons, especially if we look at the I was practicing in India, as I said in the beginning, and now I'm here. So in Africa region, we see most of the women have fibroid problems, and the main reason could be genetic predisposition. So I get women who have been operated maybe 2 or 3 or 4 times for the fibroid, and see how the fibroids cause infertility is if the fibroid is in the center of the cavity where the baby has to grow. So the baby will not get enough space, and even if one is either the fertilization will not happen, and if the fertilization
Okay, sorry about that. I think we've lost connection with Dr. Sarita. Let me just inform her just to sort of fix her connection shortly, please. Hi, Margaret. Dr. Sarita is logging in shortly. Are you able to see us?
Recording in progress.
Hello, can you hear me?
There we
I've
go.
just put my video on, and PowerPoint will open or not. Let me see. So we were talking about the factors which are female factors and the male factors.
Right.
So we were talking about the fibroids. So if the fibroids are in the uterus, then basically either they are in the cavity where the baby has to grow, so it will not give enough space for the baby to grow. Or if there are multiple fibroids, then they usually take away the blood supply from the uterus. So there can be problems with the growth of the embryo, and it can result in miscarriage. That is one of the commonest problems that we have seen in I've seen in Africa region. And the other thing is, even if they are operated, then you have to cut the uterus to take the fibroid out. So there is scarring, and the scar tissue always has less blood supply. So that can again result in either non-implantation or even decreased IVF results because of the decreased blood supply. So this is the main reason. And then the other commonest reason that we have seen is the reason for infertility in Africa region is the pelvic inflammatory diseases and the tubal blocks that come very often even in the young girls. So if the tubes are blocked, as we discussed early, then the natural pregnancy cannot happen. Just give me a second. Let me try to open the PowerPoint if I can. So those are the reasons for the infertility. Yeah, it has opened though, but I'll have to see if I can do it the screen sharing.
Okay.
Okay, so the fibroids is the most commonest reason, and then there could be tubal blockage, or there could be endometriosis. In endometriosis, again, you know, there are abnormal spots present outside the uterus. It could be on the tubes, or it could be on the ovaries. And these spots usually bleed when a woman has uh, menstruation. So from the uterus, the blood can go out, and but if the spots are on the tubes and the ovaries, then obviously these spots, the blood keeps on getting collected, and it cannot go out, and it can form a cyst. It can you see the screen now? Yeah,
Yes, we
I
can.
think you can see.
Yes.
Yeah, so in endometriosis, you can see these are the endometriotic spots which are there on the tubes and the ovaries, or it could be even in the uterine muscle wall. So if they bleed, they can form a cyst, and of course they can also affect the quality of the eggs, the number of the eggs. And in endometriosis, it is said that any girl who has been diagnosed with endometriosis. See, endometriosis is something which is related to the periods. Even if we remove the cyst, it can form again. So instead of doing the surgery again and again, it is always advisable, if the girl is in the reproductive age group, she is married, one surgery is required to have a look at the whole pelvis, fulgurate the endometriotic spots, and remove the cyst. But then they should try to conceive as early as possible, because it's a progressive disease. Even if there are some small spots which are left, they can again form a cyst. So you can't keep on doing the surgery again and again. And the other disadvantage is that when we take out the endometriotic cyst from the ovary, which is attached, it can also take away the normal tissue. So it takes away the normal eggs also. So a woman who is in her reproductive age group, she should just undergo stimulation, collect the eggs and freeze the embryos if she is married, and try for the pregnancy. If any girl who has been diagnosed with endometriosis, who is unmarried and who is not planning marriage anytime soon, she should freeze her eggs for the future use, because as I said, one, age is the main factor, and endometriosis can again affect your eggs and the egg reserve. So these are the factors which can affect the fertility in a woman. Now coming to the ovulation factors, if we check the hormone levels, and the hormone levels are on the lower side, then they might need external hormones injections in the form of gonadotropins, which can help in growing the eggs. And if the hormone levels are too high, then it is mainly a premature ovarian failure. In that case, it's very difficult to get eggs. In those cases, women might have to go for donor eggs. And then the most common reason why a woman doesn't ovulate is the polycystic ovary, in which you can see in the picture, in a normal ovary looks like this on the left side, and in a polycystic ovary, poly means there are many cysts. So there are many small cysts in the periphery, and they keep on releasing hormones, and there's a lot of hormonal imbalance, and none of the follicle grows into a normal egg. And if obviously if she doesn't have egg, she's not ovulating, the pregnancy is difficult. So in such cases, it's not that it can't be treated, it can be treated, but the only thing is she might require some sort of assistance in the form of medicines or the injections, which can help in having a good egg. And then she can she can try some form of treatment. The treatments we'll discuss in the next few slides. So these are the lab tests that we do for a woman: thyroid, prolactin, FSH, LH, estradiol, progesterone, and AMH. Why thyroid and prolactin? Because these are the two hormones which can affect the egg quality. And that is the reason whoever comes, we always check this. If there is any issue with the thyroid, if she's a hypothyroid, then we do supplement her with the thyroxine. And if the prolactin is high, it can again affect the egg quality, so that needs to be treated. And the viral markers, the sexually transmitted diseases, which can affect the tubes and the ovaries, those also needs to be seen. And anyone who comes to us, the first thing that we advise is doing a good transvaginal scan, by which we can have a look at the uterus and we can rule out a lot of things. We can look at the ovaries, we can rule out polycystic ovaries, endometriosis, fibroids, or any adhesions. So one good transvaginal ultrasound is a must for any woman, and it can give a lot of information and it can guide us as to where is the problem, and accordingly we can treat. So these are the factors which are responsible in a female. Now, it's not that only female can have a issue, so she's not able to pregnant. She's not able to get pregnant. In a male also, there can be problems, and in fact, 50% of the causes of infertility are because of the male factors. So in the males, the mainstay of the test is the semen test. We need to look at the number of the sperms, the morphology of the sperms, and the motility. And there are WHO criteria which we will see, which a man should have. Otherwise, it's difficult to have pregnancy, and then accordingly they need to be treated. Yeah, I mean, do you
Right, I
want
have
to?
a question just for that for the
Yeah.
male. There's a thin line between urologist and fertility specialist for male. How do we determine that this patient has to be seen by a fertility specialist and not a urologist, or a urologist and not a fertility specialist?
See, if it is a fertility issue, meaning if the sperm counts are on the lower side, or there are absolutely no sperms at all, then in that case, a fertility specialist needs to see the male partner. But for the, everyone needs a good general examination to have a look at the size of the testes and the epididymis, and we might have to do a scrotal ultrasound. So all those things like we as a fertility specialist are trained to do, and we can see. But if there is any say there is any obstruction and there is a recanalization which needs to be done, which is not very common nowadays, and we don't even suggest because the success rates are not very great. So instead of that, we directly go to the testes, and the testes is supposed to be the production house, and then it is transported via the epididymis in the ejaculation. So we can do a testicular biopsy. That is, we directly go into the testes and we can take out the sperms and we can use it for IVF. So that is done by fertility specialists. Now, if the person has issues with the ejaculation or with the other sexual problems, then we usually ask them to go to a urologist and see them. But otherwise, if there is a problem with the sperms and they are looking at having a baby, then everything is available in a fertility hospital. Like at IVF center, we do everything.
Right. Okay. Thank you.
Even the hormone tests, which are supposed to be done, we can have a look at like for the female, we do FSH, LH, testosterone, prolactin, thyroid, same things we do for the male to rule out the cause of the infertility, whether it is because of the low hormones or it is a testicular failure, or if the hormones are in the normal range, then obviously it's an obstruction which can be treated by doing the testicular aspiration or the testicular extraction. So all those things can be managed in a fertility center.
Okay.
So this is how we check the tubes. The tubes cannot be looked, we can just have a broad idea about that the tubes are normal. If there is a fluid that we can see on the ultrasound, but whether the tubes are blocked or open, we have to put in a fluid inside the uterus, and we can see the fluid coming out if the tubes are open. So it can be either done on an X-ray, which is called HSC, or even on the ultrasound we can do this. We can put in the saline, that sonosalpingography, that can also be done. So if we see the fluid coming, it means the tubes are okay. So this also we do at our fertility center, because this is ultrasound based test, and we can do that easily, and it's less painful also. And if we look at the uterine factors, as I said, so if there is any problem in the uterus which is occupying the place where the baby has to grow, say the fibroids are outside the uterus, then they don't need to be removed unless they are too big. But if they are coming in the cavity, they should be operated. And then once the uterus is cut, a person needs to wait for at least 3 months, because that is the time required for the healing of the uterus before we can transfer the embryo, or before she can get pregnant if the tubes are normal naturally. If there are some bands, they need to be corrected, and we need to rule out the tuberculosis, which can affect the uterus lining. And in spite of all the methods, if a person is not able to conceive, then obviously IVF and surrogacy is the last option. And sometimes, we'll find that the ovulation is okay, tubes are okay, uterus is fine, the sperms are fine, but still a couple is not able to have a child. That is when we label them as unexplained infertility, meaning there is no reason to find the reason for infertility. So in such cases, if a woman is less than 35 years of age and her egg reserve is good, like the number of eggs seen on the ultrasound, AMH, etc., everything is good, we can try timed intercourse, or we can even give them some tablets and combine it with IUI. So 2-3 trials is enough, because the IUI results, in spite of putting the sperms and the eggs together at the same time, the fertilization might not happen, and the results of IUI are only 15 to 20% all over the world. So then we have to move on to IVF and not waste too much time on the IUIs. So this is how we, but the one important thing is, if a person is young and everything is okay, we need to explain, not everybody would need some kind of intervention or treatment. There's something called timed intercourse, meaning we just track the follicle when the egg is ready, that we can do an ultrasound. And once we see that now the egg is ready, we can give them the ovulation trigger. And then we can tell them that now this 36 to 40 hours is the best time when the egg will be in the tube. And then those 2-3 days they should try. So it is exactly timing the egg and the sperms in the body so that they can meet and fertilize. And 15-20% of the couples conceive with that. So those are the factors. As you see there, I was talking about the male infertility. So this is the testis where the sperm production happens, and from here the sperms are transported, and there's a prostate gland which adds fluid for the maturation, and the semen is ejaculated. So in case somebody comes to us with the report that there are no sperms at all, which is called azoospermia, in those cases, usually we don't go by one report. It is always advisable to confirm from the another lab, or we do everything in-house at our center. So we check after 3 days of abstinence, 3 to 5 days. And if again it shows azoospermia, then obviously we label it as azoospermia. But now why, whether azoospermia is because there are no sperms being produced in the testes, or there is a problem in the transportation level, that see, if there is obstruction, then obviously the sperms are being produced, but they are not coming out. So in those cases, we need to directly go into the testes. That's called obstructive azoospermia. So we can directly go into the testes and we can take the sperms out, and that can be used for the ICSI. But whether we will get the sperms or not, the factors which are responsible, we need to have an hormonal test to find out whether it is because of obstruction or there is a problem at the pituitary level. So even men who have azoospermia, they should not get disheartened, and there are treatments available for them, and they can also have a child. So these are the tests. This is how a normal sperm looks like. It has a head, a midpiece, and a tail. So sometimes the sperms are not motile, or sometimes there are different morphological abnormalities. And sometimes the testes are not at the place where they should be, which is called cryptorchism. So there are a lot of factors which can lead to the male infertility. And so this is the WHO criteria, which we look at the semen. The count should be 15 million to have a normal pregnancy. The motility should be 32%. The live sperms should be 58%, and morphology means the normal sperms, even if they are 4%, it's enough to have a normal pregnancy. So one should always follow the WHO criteria, which are followed all over the world. And if it is mild oligoteratozoospermia, then we can offer IUI if it is between 5 and 10 range. If it is less than 5, then usually the IUI doesn't work, and then we proceed to the IVF ICSI. So shall we move on to the treatment options which are available for infertility?
Yes, we can. I think we'll just head over to the questions once we are done with treatment options and pre-fertility test, which we've already covered. Yeah.
So the treatments that are available are, one is the timed intercourse that we discussed just now. Then we have IUI, which is intrauterine insemination. Then IVF ICSI, that is intracytoplasmic sperm injection. Then we have frozen embryo transfer. If the fresh transfer has not worked, then we nowadays actually we at our center we hardly do any fresh transfers, maybe I would say 10%, but all over the world the frozen embryo transfers are giving better results, so we do that mainly. And for the preservation of fertility for the woman, as I said, because nowadays women are marrying late, or because of their education and career, or remarriage, divorce is happening. So for such women who are not planning to have pregnancy, they should freeze their eggs, which can be used later on. So if the eggs are frozen at the age of 30, and if you use it at the age of 40, then you have stopped your biological clock at that age. So the pregnancy results at 40, if you have frozen your eggs in 30s, will be much better than if you freeze your eggs later. So the young girls are usually not aware about this, and I tell everyone that please go and freeze your eggs, because if the girls come in the age of 40, 45, when they are settled, everything is okay, and then they want to start a family, then usually, we don't get good eggs. And if the eggs are not there, then we can hardly do anything, and then they have to resort to taking donor eggs, meaning they have to take eggs from somebody, and we fertilize it with the husband's sperms. Similarly, for men also, we can freeze the sperms, even the embryos can be frozen. And in male infertility, we can do the testicular aspiration, and then it can be used for IVF. Then somebody who has had multiple miscarriages, or we get a lot of patients who have repeated IVF failures. For those, the main reason for the IVF failure is the chromosomal abnormalities, because after the age of 40, it is seen that 50% of the embryos come out abnormal. So if we don't check and we just put in the embryos, then and they fail, then we can't be just doing that again and again, and because it's obviously a financial and an emotional trauma for the woman. So it's always better to check the embryos, find out whether they are normal or abnormal, and then do the transfer. So it saves the failures. So pre-implantation genetic testing can be done. One is for the chromosomes and other also for the diseases. Like if somebody has thalassemia, and if a husband and wife both have thalassemia or sickle cell disease, and if the child is born with a major disease, then it's very difficult to manage. So we can prevent having a child like that, and we can send the embryos and we can test before even transferring whether this embryo is free of disease or not. So I've seen in Uganda, sickle cell is quite common, and even thalassemia. And a lot of couples have come and they have had successful pregnancies with this. Then family balancing can be also done, in which if somebody has boys, they want a girl. So again, through pre-implantation genetic screening, that is possible here. So now coming into, we'll discuss in short about the treatment options. So this is how the IUI is done, the intrauterine insemination, in which we, the treatment for whether it's IUI or IVF, it starts at the beginning of cycle. We tell the woman to come on the second or third day, and we put them on some tablets as well as the injections, so that instead of one egg, there are 2 or 3 eggs, because if there are 2 or 3 eggs, the chances are better that at least one egg will be fertilized. So we monitor the egg, and once the egg is ready, she is given a trigger, and the same day husband's sperms are taken, they are washed with medias in which the dead sperms and the abnormal cells are all separated, and we have good sperms, which are motile sperms, which are injected into the uterus. We go in the center of the uterus so that the sperms can easily go to the tubes and fertilize the egg. So this is how the IUI, intrauterine insemination, is done. As I said, the intrauterine insemination, again, the results are only 15 to 20%. So it is not advisable to do too many IUIs, although there are different guidelines available. But most of the doctors, like even I personally, do maximum 2 to 3 good cycles of IUI. And if it is not working, it's better to move on to IVF. Of course, IVF is expensive. IUI is a slightly cheaper option. People who can't afford, we do try IUI, but the results are not very encouraging. It's maximum 20%. Now coming to IVF, IVF is in vitro. In vitro means we are fertilizing the sperm and the egg outside the body. So here again, we give the injections so that a woman has a certain number of eggs. And once the eggs are ready, we go through the ultrasound into the ovaries, and the eggs are aspirated in the tube. And once we have these eggs, the same day a man is asked to give the sperms, and then they are fertilized through ICSI. And once we have the embryos, they are transferred back into the uterus. So this treatment also works for the tubal block, because here we are bypassing the tubes. So you can see it. This is how the ultrasound monitoring is done. And we go into the ovary and suck the egg out. All the eggs are taken out, and then under the microscope, the embryologist will fertilize the eggs. One sperm is picked up and one sperm is injected into the egg. That is called ICSI. And once we do the ICSI, the embryo starts growing, and we can take the embryo up to, they are put in certain incubators and the media where they are given exactly the same temperature, pH, and the nutrients which are there in the body. So we can grow them up to day 3 or day 5, depending on how many eggs and embryos are there. And then we pick up, usually less than age 35, we pick up only 1 or 2 embryos. And if it is more than 35, depending upon the embryo quality, we can transfer 2 or 3 embryos. So this is how the embryos are placed into the uterus. We put 2, hoping that at least 1 will stay. But sometimes if the embryos are good, then even both the embryos can grow. So the chances of multiple pregnancies are about 20% when a couple is undergoing any kind of treatment. So as I said, we transfer 1 or 2 embryos, but if somebody is young and we have extra embryos, these embryos are kept frozen for a later use, and the embryos can be frozen for as long as the couple wants. Suppose she has conceived 1 and the embryos are still there. So we can freeze them for 1 year, 2 years, 5 years. The maximum that somebody has conceived is 20 years. So they had frozen the embryos for 20 years and then they were transferred and still they could get a baby. And this is how we do the PGS. So this is a day 3 embryo, which has about 6 to 8 cells. So a very small piece of the cell is taken out by putting a laser, making a small opening, and this tissue is taken out, and then it is sent to the PGD lab for testing. And we get the results like this, that this embryo is abnormal, this is abnormal, and then so they are numbered and we get the result for each and every embryo, and then we pick up the embryo which is normal and then it is transferred. So the results after the genetic testing are obviously higher, and people who have had repeated miscarriages or who have repeated IVF failures, for them this is the gold standard. So the biopsy can be done on day 3 or it can be done on day 5. And we have all these facilities available at our center. We have full-time embryologists, there's a modular lab, ultrasound I do myself personally, and the treatments that I mentioned, everything is available. And we even have laser hatching, in which, once the embryos are frozen, so the outer covering becomes thick. So sometimes the IVF might not work and the embryo might not be able to hatch out and attach to the uterus. So we make a small hole with the laser, and so that the embryo can, so we do it for a lot of patients, and there are no extra charges. It is just because we want to have best results for the patients. And the blastocyst culture is taking the embryos up to day 5, and that is available. And people who do not have their own eggs, donor semen, donor oocytes, that is because if that is the only option, then we do have facility for that also. Even embryo donation is available. Family balancing, laparoscopy, hysteroscopy, tubal surgeries, septum resection, etc. Everything we do. See, people who have tubal blockage, if they are young, then we can, if woman is older, then obviously the surgery is not of much use. Then IVF is a better option. Then the other issue that I see here very commonly is the HIV positivity and even hepatitis B patients positive who come. So we do treat them also. We do the 2-3 times the semen is washed, and then the PCR of the semen sample is sent. Once we get the report that it is negative, then it is as good as a normal semen. And for the hepatitis and HIV patients, we have everything separate. There is a separate lab, separate incubators, separate tanks, so that there is no cross infection, and they can also have a baby. Thank you for hearing, and if anyone has any more questions, I've tried to cover a lot of things related to infertility. If you have any more questions, you're most welcome to ask.
Presentation and insight on infertility. We've truly learned a lot. It was a learning experience for sure. I don't know whether I should just dive into the questions just for us to sort of answer, for you, Doc, to answer for us most of the questions that patients really have that have asked. So there's one patient who has asked, how come she's not responding to the ovarian stimulation drugs?
If somebody is not responding, then we need to see the hormone levels, either the amount of drugs that is being given is not adequate, or if her hormone levels are too high, then if she is going into failure, then so we need to look into that. And it is especially in the polycystic ovaries, where sometimes patients do not respond for a long time, so we have to give them slowly and slowly step up the dose. Then once a threshold is reached, then the follicles might start appearing. So one needs to be patient in those cases, and she might need a longer stimulation for the follicles and the eggs to appear.
Okay, thank you for that. So another question asked is, how long can embryo freezing be stored?
This I mentioned in the this presentation only, that the embryos can be frozen for as long as a person wants, because they are in the liquid nitrogen. So unless we take them out and we thaw them, they remain live in the minus 196 degrees liquid nitrogen, and we can store them for many years actually.
Okay, so does the same apply for sperm and egg as well?
Eggs also, yes. It applies to all the gametes also and the embryos also.
Okay. There's another question of a patient asking, what impact does infertility have on psychological well-being?
Of course, there is a lot of trauma, a woman who is not able to conceive. Every woman wants to have their own biological child, and if she's not able to have, then it affects her in a lot of ways, like emotionally, she might not be very stable and she might be very unhappy. Plus, in our society, woman is blamed that she cannot have a child, and a lot of societies actually. And the man there can be a lot of divorces happening because of that. They leave the wife and they marry another woman just to have a child. So obviously it affects her, the well-being of the woman. She's left alone, and it is a emotional and a psychological trauma for the woman. So there are a lot of things available now. Of course, it does cost little money, because these treatments are little expensive, IVF, etc. But sometimes, if a woman conceived by IUI or even a simpler method, then it's not that expensive. So they should actually go and see a fertility specialist who can offer the treatment as per the diagnosis, and then she can have a child.
Okay. A question that I wanted to ask you, are there symptoms for infertility in females? Is there a way that, without necessarily doing any test, that a female can know that I'm infertile?
Actually, it's a little difficult without testing to find out exact reason. We need to find out exact reason. Suppose if somebody comes to me and I give her just the fertility drugs and I do the IUI, and after 2-3 months we check the tubes and tubes are blocked. So the treatment that you have given, it all goes waste. So we need to find out a particular reason, what is the reason, and then accordingly we should treat the infertility. So the tests are required for that. Yeah.
Okay. Another question asked here is, I don't know, Doc, whether you're free to answer this in terms of cost. A patient is asking, how much does it cost to test embryos, and does it affect the stability of the embryos?
So the cost for testing of the embryos is usually we have kept it as 250,000 Kenyan shillings for testing up to 6 embryos. Usually they charge about $400 for each embryo.
Yeah.
And because there is no VGS lab available in the whole of Kenya, so what we do is we have the laser and the embryologist is trained to do the biopsy. So we take the biopsy here, and that biopsy tissue can be kept for even 1 month or 2 months, although we send every month. So there are certain medias in which those tissues are kept, and then those tissues are transported to Dubai, and we make sure that the samples reach within 24 hours to the lab, and there they are tested. So we have tie-up with Dubai as well as Egypt Center, and that is where we send, and the reports are usually available in a week's time. And when we are sending the embryos for testing, it has to be anyways a frozen transfer, because we can't transfer the embryos after day 5. So day 5, we take the biopsy, and then the embryos are frozen. They are sent for testings. In week to 10 days time, we get the result. So by that time, a woman has periods, and then we can prepare her for the transfer.
Okay, wow, that's interesting. Another question asked is, if a woman has no uterus, how can you help her conceive?
See, if a woman doesn't have uterus, then obviously, if she has ovaries, it means the eggs are there. So we can take out her eggs, we can fertilize it with her husband's sperms, and we can, so the child is theirs basically, but they need someone to carry it. So we can offer a surrogate, and these are the genuine cases who need surrogacy. So the embryo is transferred into a surrogate, and of course there are papers which she needs to sign. It is done properly legally, and then once the surrogate, she knows that she's carrying for someone, so she hands over the baby once it is delivered. So there are some cases genuinely, like somebody having this kind of a situation. We recently had a girl at our center whose uterus was removed for some reason somewhere, and she was very young. So we got eggs, and her surrogate is already pregnant, and she knows that she is carrying the child for somebody. For such cases, the surrogacy does help.
Okay. Another question asked is, are there risks of having a baby through IVF, and what affects the IVF success?
See, there have been a lot of studies, and even people have followed the children who have been born through IVF. So there are no abnormalities found in the IVF babies. It is as good as a normal, as when the couple conceives naturally. And the success rates of the IVF again depends on a lot of factors. One is most important is the clinician and the lab. We have to have a very good lab which should not have any kind of infection. The air quality matters a lot, how they are fertilized and which kind of incubators are used, the embryologist skill, all those things are important. But in a patient, again, it's not that even if you have good embryos, sometimes you don't get a pregnancy. So we need to see a lot of factors. There could be problem with the egg, there could be problem with the sperms, there could be problem with the embryo, there could be problem with the uterus. So there are a lot of things which need to be seen, which can give us a pregnancy.
Okay.
Yeah.
There's a question asked here. A patient says, my wife has one fibroid. Do we need to get surgery before going for IVF?
So it depends, where the fibroid is. If the fibroid is in the center, it is occupying, sitting in the cavity where the baby has to grow, then it will obviously interfere with the baby's growth. So those fibroids need to be removed. And if the fibroids are outside, it can be, if it is not coming into the cavity, say it is in only the wall, or it is completely outside, then they might not need, but it is said that if the fibroids are more than 5 centimeters and they are multiple in number, then we do try once to transfer the embryos if they are not in the cavity. But if it doesn't work, then it is advisable to remove them. And once the fibroids are removed, they need to wait for 3 to 4 months, which is the healing time required for the uterus, and then they should go for the transfer.
Okay. Another question asked is, at what age should men start getting concerned about quality of sperm?
Usually after the age of say 55, if we compare the sperm parameters of the younger guys and the older guys, we see there are a lot of abnormal sperms. The motility reduces and there can be a lot of DNA fragmentation, which can result in abnormal embryos, and it might not give a pregnancy. So usually we say after the age of 55, even the males, the sperm quality does get affected.
Okay, because he goes ahead and says, the patient now goes ahead and asks, if beyond 50, what are the chances of birth defects? Are they higher due to the man's poor sperm quality? Okay.
Yes. So it is same with the men and women. So if a woman is above 40, then the chances of abnormal embryos are very high. And if a man is above 50, 55, then again there could be an abnormal embryo. In such cases, if they are going for pregnancy, it is advisable to do pre-implantation genetic testing to say out of 10 embryos, even if we get 2 good embryos or 1 good embryo, that's good enough. Then, and we transfer those embryos, then the chances of pregnancy are good and chances of having a normal baby are good. But if we just transfer randomly and if the embryo is abnormal, even if it starts growing, it ends up in miscarriage. One, it might not grow. And if it grows, it can end up in miscarriage.
Okay. Okay, so another question is, does transfer of embryos from one lab to another affect them?
No, it doesn't affect too much, provided that they are given by an embryologist who know how to handle the embryos, because they have to be in the liquid nitrogen. From one tank they have to be transferred to the other tank immediately. So if it is done properly, it doesn't affect the embryos transferring from one place to the other. Yeah.
Okay, so let me just wrap up just 2 more questions, then we wrap up. So someone has asked, when someone has a low ovarian reserve, what is the best option for stimulation of the ovaries? Is it high or low stimulation?
See, nowadays, if the egg reserve is low and the older woman, we say that the minimal stimulation, in which we give some tablets and a low dose of injections, that gives better eggs and it gives better embryos. So we do offer minimal stimulation protocols along with the conventional one. So for the lower ovarian reserve, that is preferred. We might have to give her maybe instead of 1 stimulation, we might have to give 2 or 3 stimulations, but then the cost is accordingly adjusted. And the other thing which is now available for the low ovarian reserve patients is there are newer treatments, although they are experimental, but they are being used. Like in India, before I moved here, we had already started doing that. That is called PRP treatment, platelet-rich plasma, in which the patient's blood is taken, it is centrifuged, and the platelet-rich plasma is supposed to be having a lot of growth factors. So that is injected into the ovaries, and we wait for 4 to 6 weeks for the plasma to act in the ovaries and stimulate the growth of eggs. So PRP treatment is available at our center, and even the stem cell therapy, which is again being tried in a lot of patients, a lot of papers are coming up, and that is also available. So for those patients, we can try that. But there's no 100% guarantee that they will make an egg, but it does give some advantage. So we do offer those also. Similarly, the PRP treatment in some women who do not have a very good uterus lining. For them also, we do offer this treatment. So this is available at our center.
Okay. Okay, so one of the last questions that we have, someone is asking, a patient, sorry, is asking, if someone takes up IVF with donor egg, to what extent will this child have the mother's genes or any similarity?
So see, the child will have the genes of the gametes. So if we take a donor egg, then the child will have features and the genes of the egg from whom the egg is being taken.
Right.
So it is like 50% of the genetic material is yours. You have the donor egg and you have the husband's sperms. So the child might take either we don't know whether the child will take father's features or mother. Sometimes the child is entirely on father. So the features will be of the donor eggs and the father with whose sperms the eggs are fertilized. But in donor eggs, we try to match the features as well as some other features like the eye color, the hair color, and the education level, the blood group, etc., to match with the actual biological mother, so that the child gets features which are similar to the mother. So that is how it works.
Okay.
So somebody has also asked what is the cost of consultation, and so we do have. You can visit the center. You're most welcome anytime. We are open from 9 to 5, and Saturday also we are open till 2, 3. And I do take online consultations. The consultation charges are 3,000 shillings.
Yeah, that was actually one of the last questions I wanted to wrap it up with.
Yeah, and the numbers are, I think, they were there in my slide. You can call on the clinic number 786-656-236, or you can even call me on 786-404-972. We'll be happy to advise you on any kind of infertility treatment.
Okay, just Doc, one last question as we wrap up now. A patient just asked, must you have a HCG test if you'd like to only freeze your eggs?
Sorry?
A patient, the last question, Doc, patient is asking, must you have a HCG test if you'd like to only freeze your eggs?
HSG test. No, HSG test is not required. HSG is basically to check the tubes. So the tubes are different, the ovaries are different. So if you want to freeze your eggs, HSG is not required. But yes, we advise to do a hormonal profile, the AMH, thyroid, prolactin, etc., and the ultrasound. That's it.
Okay. All right, then. Thank you so much, Doc. We really, really appreciate your great insight on matters regarding infertility. We truly appreciate that, you've given us so much information that we can ponder into and, understand more on infertility. We really, really appreciate it a lot. In terms of also the audience as well, we'd like to thank you so much for engaging with us, sending the questions. Please continue sending them. We can give you a phone number for you guys to send the inquiries to, so that we can, get you guys to reach out to Dr. Sarita and, book the appointments. We can also assist from our end as well. We'll also share a number also, just for patients who want our way of sort of helping you to get to Dr. Sarita. Yeah, we really, really appreciate that. We'll also send that as well. Our phone number is 0742 006 066. That's for My Health Africa. In the case that you'd like to book with Dr. Sarita, or send an email to Elizabeth@myhealthafrica or drsarita2007@gmail.com. Yeah. All right, then. I think, Doc, this is it from our end. Really appreciate it.
Okay.
Yeah. Thank you, everyone.
Thank you so much. Thank you.